Hi, everybody. I'm Tim Hughes from Adelaide, Australia.
Hello, everyone, and I'm Ehab Atallah from the Medical College of Wisconsin.
Great. So we'll get going. The topic today is our practical approach to treatment-free remission, and I guess we're looking at getting two perspectives from two different countries. So, firstly, Ehab, I'd like to know how you talk to your patients about treatment-free remission. Is it something that you bring up in your first discussion? Do you wait until they've achieved a deep response? How do you approach that with your patients?
I think in the first discussion, I'm a little careful. What I say is, many years from now, if you take your drug perfectly and you get into a deep remission, then we will discuss stopping. But this will be 4 to 5 years from now. We're not going to talk about it right now. And the reason I say this is to encourage compliance. We know that only a small percentage will have this undetectable or MR4 earlier on. It's going to take a while. And set expectations. Like, I don't want them to think that, I'm definitely going to get off the drug, because at the end of the day, only 20% will be successful in that. And as time goes by, then I talk about it more and more and just sort of encourage compliance more.
Yeah, I think my approach is pretty similar. I find it hard to avoid referring to treatment-free remission because often it's one of the major drivers to using a second-generation drug. I mean, why else am I using it? So if I want them to make an informed decision, I want them to understand what the potential benefits of a second-generation drug. And I believe that one of the potential benefits is getting more patients to be eligible, but also getting more patients to be eligible at an earlier time point. But I certainly don't hold out any expectations for them to get to that point in the next few years. I say it's something down the track, but the message really is, if you take this drug every day, there may come a time when you can stop taking it altogether. That is our ultimate aim, but we can't always achieve that. So I think that's a very similar discussion. I think probably 5 years ago, I didn't talk about it at diagnosis. I thought it was just too theoretical and not really well established. But now I think we have enough information to start to address it. It's one of the many things we talk about. So it might not be in the first interview, but it might be in the second discussion when we're honing in on which drug to use, I guess. So ideally, we try and make that discussion over a couple of consultations. So are there patients that you bring this in earlier and more emphatically, and others that you won't really talk about it at all? How do you kind of select the patients where this becomes a major topic over their journey?
Over the journey, so the younger patients, especially that are having more side effects, sort of encourage them, tell them, yes, you might be having fatigue, or if we can't adjust it, just give it more time. We know that there is a good chance, especially if they start hitting their milestones earlier on and they're doing really well. I use that as to encourage them, like, well, you just hold on. Things are looking good. Another 2 years and we will consider that. I'm also careful with the younger patients, and I don't know what your experience has been. But younger patients are not very adherent to their medications. I mean, they don't want to have a little bit of fatigue. They don't want to have a little bit of diarrhea. They're busy at work. They have different schedules. So I'm very cautious also with the younger patients, because if the doctor said, there's a possibility I would stop, they will just decide, well, maybe I'll just stop. What's your experience with that?
Yeah, you probably didn't have that experience. I'm not sure you were treating patients in the early phase of imatinib, but we didn't have any real expectation of treatment-free remission. And it was very difficult to persuade a patient that they were on this drug, which gives them, unpleasant swelling around their eyes and headaches, this is it for life. And particularly younger patients, and particularly men, I would have to say, would be quite challenging in that setting. And that's where I find having that potential focus of treatment-free remission is so helpful, because it's not like, this is diabetes or blood pressure where you're stuck on drugs for the rest of your life. There is actually a pathway out for many patients, I believe many patients. And so I use it as a motivating device, so that I can get patients who are young and can't really contemplate the idea of taking a drug for 60 years. The fact that there is a potential, particularly if they're hitting their targets, as you say, that we'll be able to get them off drugs. So some pain in the next year or two will have a reward. So I think that really helps the whole discussion about compliance. When you do have a patient, Ehab, who is clearly eligible, they might have been on imatinib for 6 or 7 years, they've been PCR negative, MR4.5 for 2 or 3 years. You've mentioned to them the possibility of this. How do you find that the majority are immediately enthusiastic? Do you find a lot of reluctance? How do you find that patients generally receive you when you start bringing this up as a kind of a reality in the next year or so?
I think that also has changed with time, right? Like the earlier on, like 6, 7 years ago, when even I was a little hesitant, like I wasn't sure, like, is this really going to work? I mean, there's data out there, we're not sure. Now, especially that it's brought up, they look up online. Treatment-free remission is a real thing. It's becoming more and more acceptable. I do have a few patients who just, like, no matter, like even up to last year, like they fit perfect. They've been on drug for 10 years, especially they've been on drug for 10 years. Like, this is working, leave me alone, right? Yeah. And some of those patients, I sometimes reduce, have a discussion with them, not push them, tell them this is very normal. And sometimes I reduce their dose, see how they do, how they're feeling, and monitor them. And that gives them some reassurance, like reducing the dose, oh, I'm still good. Okay, now I can stop. And it's worked with some of them that were pretty anxious about it.
Yeah, that's an interesting approach. It's certainly one that I was really concerned about when it first started to be talked about. I thought that this was a recipe for resistance and disaster to talk about halving doses. But we now have pretty good data. We have the Destiny study, which looks really quite promising, where patients had their dose halved for a year. I mean, some did lose response, but got back on drug again. But many of them did then subsequently achieve treatment-free remission. So I maybe reluctantly have come over to that belief that we can halve a dose. And for some patients, that's a reassuring first step into the water rather than diving in. So I think that's a reasonable thing to do. And I've certainly tried that in a few patients recently. But there still are some patients in my own practice who still have that mantra, this drug saved my life, doctor. I'm not leaving this drug alone. And, at least at this stage, a lot of those patients, it's imatinib, and it's not probably doing a substantial amount of long-term damage, maybe a bit of renal impairment in the long term. But, I think we need to take their feelings into consideration and keep going. And there may be a point where the data is so strong that we need to push harder, but I think it's very reasonable today to accept that there are patients who are reluctant. So when you talk to a patient about treatment-free remission, how do you talk to them about the risks?
So I say, we're going to stop. You'll have 3 main problems is what I think of it. First is anxiety, right? And that's something we've seen in the last study is, they're taking their pill every day. They come in for checkups every 3 to 6 months with their PCRs, and things are just very steady, right? Now they're going to have to come in for more frequent monitoring, waiting for their PCR. So that's the first risk. And the anxiety of seeing a PCR going from undetectable to detectable. So I discussed that very clearly. The second risk is the withdrawal syndrome with the joint pain. We discussed that in detail. And the third risk, which really was highlighted with COVID, is all the visits that you need to do to the hospital now. So instead of coming every 3 to 6 months, now it's monthly for the first 6 months and then every 2 months. So a lot more visits to the clinic compared to where they were before. So I discussed with them these 3 things ahead. And I think once we do that, it works quite well.
Yeah. Okay. So we have a similar approach. I guess I emphasize to the patient that this is not a life or death situation. We're just trying to find out whether you still need your drug. Some patients are still taking the drug and actually don't need it anymore. They can maintain remission without it. But some patients clearly are dependent on their drug, and we're not going to know that until we stop it for a period. And if it starts to come back, we then know where we are. You need this drug, and we go back on again with a longer term plan. Whereas for other patients, it's clearly a way of getting off their drug altogether. So don't place it as sort of a, oh my God, you might relapse and that's going to be terrible, because it's really just finding out whether they need the drug. Secondly, and really important to talk about withdrawal. I've had a patient not so long ago who I probably didn't put enough emphasis on the likelihood of withdrawal, and was quite an intelligent person who was very alarmed when they started to get achy and feeling unwell that the disease was coming back, and spent a lot of time extremely anxious before I was able to reassure them this was withdrawal syndrome. So it's an important discussion to have. And I guess also the discussion to have is if you do need to go back on drug, what they'll go back onto. And that's a discussion I think that's good to have beforehand, so they're ready when they do need to go back on, that they can go straight back onto their therapy. We don't have the same issue about having to come to the clinic every month because we have pathology labs all around the state, and so a patient who's in the country, for instance, will just go to their local country blood taking service, have their PCR test, we'll ring them up and tell them where they are. So it doesn't involve monthly visits. But maybe that doesn't fit so well into the American health system. I don't know, but it's not an issue for us.
No, what I meant visits, not necessarily that I would see them, but essentially
Right.
going to a lab, going to have blood taken as opposed to just once a year and every 3 months. Just a much more serene schedule.
Yes, I know it is stressful, that monthly test. And that's why I try and de-stress that by emphasize that it's not life or death as to whether you become positive again. It's just finding out whether you need the drug. So I guess that brings us to the situation of the patients who do need to go back on drug. Do you always put them back on the same drug?
I'd say 80% go back on the same drug, mostly because they know it, they've tried it. Very few immediately go, I'd say maximum, 20% maximum have shifted to another drug when we with the restart.
Yeah, pretty similar for us. I mean, I tend to prefer them to go back on the drug. I know that they, well, hopefully we're tolerating it reasonably well and they're responsive to it. I'm nervous about putting them back on putting straight onto a new drug where they might get significant toxicity early on, and therefore there might be a situation where they're above 1% but not able to take their drug. So I tend to get them back on the same drug, and then when they're back into a major molecular response, or ideally a deep response in about 3 months or so, then if it's been, perhaps nilotinib for the last 5 or 6 years, we're now looking at probably much longer exposure to a drug. I'll be starting to talk about changing to something with lower vascular risk, probably even imatinib if that was appropriate. So I think you can make that sort of switch, but I don't think it's a good idea to do it very often straight away, unless it really was, they stopped because they had unbearable side effects with their drug. We're coming close to the end, but sorry, did you have a comment? No.
Oh, no, I just didn't know we talked that fast.
Yeah. So when you do have a patient who's back on their drug, what do you tell them about their long-term prospects? Because clearly their big chance of getting off therapy is over. How do you deal with that?
Deal with that with discussing, especially if they're having side effects, discussing a lower dose. We do have a couple of one clinical trial that's open, and another study that's about to be open to attempt second TFR. And I think just looking at the data, the chances for a successful second TFR depends on how fast they lost MMR after their first attempt.
Yeah.
So the patients who stayed longer in remission, I give them a little bit of hope, say, you go back on this, we may reduce your dose, try again, but not now, in many years from now.
Yeah, we have a similar approach. I mean, we do attempt second treatment-free remission, but we would generally wait 4 or 5 years back in deep response. And we've had reasonable success with that sort of approach. So I certainly don't tell them that that's it for life. They're stuck on drug for life. I just say, look, there may be a second opportunity, but we're going to get this really back into a solid deep remission for several years before we contemplate that. A little bit like the message earlier on, actually. But so I don't leave them with no hope that they'll get off therapy. So I guess that brings us to the question in your own practice. What would you say out of your cohort of patients, what percentage are in treatment-free remission?
Oh, that's so hard. I'd say, well, because we did have the trial, so I did see a few more patients for that specifically. But I wouldn't say more than 30% are in treatment-free remission at this point. Yeah.
Do you believe with time we're going to get that number up to a much higher level, or do you think that you either are a candidate or you're not a candidate for treatment-free? In other words, some patients will just or maybe the majority will never get there, or is it just a matter of time?
I think I know we've had this discussion. I think the majority will not get there with just the TKI alone. I think we have to do other things, other drugs, other pathways, which of course doing research in that area is getting to be more and more difficult, because what are we going to accept for side effects? But I don't think the percentage will reach, for example, 80% being off drug. I think we're stuck in the 20-30% in the big picture going off drug.
And what do you think would be the strategy to substantially increase that? Do you think it's approaching the eradication of a residual cell, a leukemic cell, or is it optimizing the immune parameters?
I think eradicating the leukemia cell. I know there's lots of data out there for optimizing the immune system. I'm also very interested in the telomere theory, which as we get older, we're more likely to get to a TFR. And I think that does follow the telomere theory, if that's true. And I think I also love your data on the compartments of the BCR-ABL being present in the lymphocytic component, not the granulocytes. I think these things will help us in defining better who can stop, so we can have more confidence. But of course, we're pretty far from clinical practice to apply those in clinical practice.
Yeah, great. Look, thanks a lot, Ehab. I think we have a lot in common in our enthusiasm for TFR and also our caution about it, because it clearly can be easily misused. But that's great. I've enjoyed our discussion. Thanks a lot.
Thank you so much, Tim. Have a great day.